Hello, everyone, and welcome to the Radiology Cardiothoracic Imaging podcast. My name is Sonia Barra, and I'm the editor-in-chief of the journal Radiology Cardiothoracic Imaging. The host of our podcast is Praveen Ranganath from Dallas, Texas.
Hey, Dr. Ibarra. Hello, everyone.
Hi, Praveen. In this series of podcasts, we will break down recent articles and trending topics from the journal through conversations with the authors, the editors, and experts in the field. For all of you out there interested in cardiothoracic imaging, subscribe and listen to the podcast to keep up to date with recent developments in cardiothoracic imaging.
Hello again, listeners, and welcome back to the Radiology Cardiothoracic Imaging Journal podcast. I am your host, Praveen Ranganath. On today's episode, we will discuss a recently published review in the journal. The review is titled Chronic Lung Allograft Dysfunction, a review of CT and pathologic findings. This paper comes to us from our colleagues in Vancouver, Canada. The lead authors are Dr. Danielle Byrne, Dr. Roland Nador, and Dr. John English. The senior author is Dr. Anna Maria Bilowich. Despite the many contemporary advances in transplant medicine, lung transplantation is still plagued by significant morbidity and mortality, with a reported 5-year survival rate of only around 59% post-transplant. As many in our audience know, a significant contributor to post-transplant morbidity and mortality is chronic lung allograft dysfunction, or CLAD for short. The pathophysiology of CLAD is complex, and there are obstructive and restrictive phenotypes that have been described. It's thought that CLAD results from a combination of acute, subacute, and chronic interstitial and airspace diseases. It is imperative for thoracic imagers to learn the nuances of CLAD to understand its manifestations on imaging. Our featured paper blends clinical, pathological, and radiological information together in a comprehensive yet concise review of CLAD. The review provides excellent CT and corresponding pathology images to hammer the teaching points home. On this episode, I have the privilege of speaking with the lead authors of this featured publication. Let's get into that conversation now. All right, hello listeners, and welcome back. I have with me the lead authors on our featured publication, Danielle Byrne, John English, and Roland Nador. Welcome on board, everyone.
Thank you. Thanks for having us.
Thank you.
Excellent. So as a reminder to our listeners, the title of the featured publication on today's episode is Chronic Lung Allograft Dysfunction, Review of CT and Pathologic Findings. So before we dive into that publication, let's learn a little bit about everyone here in the conversation. Tell us a little bit about who you are, where you work, and what your academic interests are. Danielle, why don't we begin with you?
Thanks. Yes, I work as a consultant radiologist in St. James's Hospital in Dublin, Ireland, and my main interests are cardiothoracic radiology and neuroradiology.
Spectacular. John, how about yourself?
Yeah, thank you very much. Yes, John English here. I'm a consultant pathologist with a special interest in thoracic pathology at the Vancouver General Hospital. I'm also a clinical professor of pathology at the University of British Columbia.
Excellent. And finally, Roland?
Yeah, I'm a transplant pulmonologist here in Vancouver. I was trained in the States at Stanford previously and worked also in Edmonton, which is another large center after Stanford. And my research interest in the past was tolerance induction in solid organ transplantation. And currently the clinical aspect of immunology, antibody-mediated rejection, and obviously chronic lung allograft dysfunction are the main interests.
Yeah, spectacular. We have a nice multidisciplinary conversation ahead of us. I love it. So why don't we go ahead and begin? Our listeners out there are likely familiar with other post-transplant related complications, for example, acute cellular rejection, opportunistic infections, drug toxicity, and even disease recurrence. So how does chronic lung allograft dysfunction, which we'll abbreviate as CLAD, relate to these other post-transplant complications in terms of time of presentation and overall incidence?
First, so I would like to say that there are quite defined risk factors for chronic lung allograft dysfunction. And some of them, as you listed here, such as acute cellular rejection and some of the opportunistic infection, are considered risk factors. More importantly, we'd like to say that nowadays we consider more so acute cellular rejection is just one type of a acute lung allograft dysfunction or an acute rejection. There are many other forms, and radiologists might be actually familiar with that. There is the organizing pneumonia pattern of acute lung allograft dysfunction or acute rejection. There is the diffuse alveolar damage. There is the bronchial type of acute cellular rejection as lymphocytic bronchiolitis. And there are some others that are not as well defined, such as the eosinophilic acute lung allograft dysfunction, which might or might not be associated with acute cellular rejection. Sometimes on radiographic imaging can present as an eosinophilic pneumonia pattern, well known from the immunocompetent population. But obviously, there are many others, and I would just like to point out some that might not be as well known, that respiratory viral infections have been considered for a long time, and more data is showing that will be associated with the development of chronic lung allograft dysfunction, and they can be also associated with triggering acute rejection episodes at the time of infection, but down in the road, they will trigger chronic lung allograft dysfunction. And then others that you might be very familiar is CMV pneumonitis, antibody-mediated rejection, together or in conjunction with acute cellular rejection or even eosinophilic acute lung allograft dysfunction can be risk factors. So obviously there are different studies showing that the frequency and the grade of acute cellular rejection is associated with the development of chronic lung allograft dysfunction, and some of them more associated with the development of obstructive chronic lung allograft dysfunction, such as lymphocytic bronchiolitis, whereas others, such as the organizing pneumonia pattern, the antibody-mediated rejection, and even the diffuse alveolar damage type of patterns would be more towards developing a restrictive allograft syndrome. Since you listed drug toxicity and disease recurrence, those are not or have not been so far linked to the development of chronic lung allograft dysfunction. Although I have to say that if you think about sarcoidosis and a constant inflammatory state which recurs in the transplanted organ, it most likely could be, it's very conceivable that it could be. But for example, the recurrence as such as LAM or let's say idiopathic pulmonary hemosiderosis, those are going to affect lung function, but it depends on the definition of chronic lung allograft dysfunction, what you consider, whether it's an immune phenomenon or a non-immune, and so on.
Yeah, Roland, thank you very much. That really dovetails nicely in what I would like to review next, which is the pathogenesis behind this. So your review really contains an excellent breakdown of the complex pathogenesis behind CLAD, or chronic lung allograft dysfunction. In general, is the pathogenesis of CLAD similar to that of any other diseases with which our audience may be familiar?
Yeah, thanks for your question there. Well, there are two different forms of CLAD, as we know. The obstructive form relates to essentially small airway disease, and the restrictive form manifests as an interstitial and airspace pathology, sometimes combined, as Dr. Nader has alluded to already. It's kind of difficult to determine the precise mechanisms by which allorejection, the overarching factor here, although as Roland said, there are other forms as well. It's difficult to determine which or both of all these forms results in what looks like a seemingly disparate process. And I think your listenership would recognize the differences in small airway disease radiologic manifestations versus the more interstitial processes. And I think Dr. Byrne will address those. If we consider obstructive CLAD, however, essentially all of the entities begin with some form of small airway inflammation. And I'm going to be just listing a few things that your audience may be familiar with and other disease states. ultimately it's going to lead to something called bronchiolitis obliterans. And I should just maybe preface this by saying that the terms bronchiolitis obliterans and obliterative bronchiolitis are often used synonymously. And it's sort of the curse of physicians, not to mention pathologists, that we can find many different names for the same thing and split terms in a quest to be very precise. But nevertheless, if we do use those terms BO and OB, or you see them in literature, that's what they mean. So for the hallmark lesion of certainly of obstructive clad is bronchiolitis obliterans. And other entities that we can see this in would be, perhaps the most famous one would be pulmonary graft versus host disease, also an allo reaction, where lymphocytic bronchiolitis probably gives way to the more fibrosing form of small airway disease. We can see bronchiolitis obliterans, of course, in connective tissue related ILD syndromes, particularly rheumatoid arthritis, but others as well. And naturally, anything that inflames the small airways, post-infection like mycoplasma, RSV, paramyxoviruses, other viruses, radiation, some drugs, fumes, inhalation exposures. And of course, there's a significant component of idiopathic bronchiolitis obliterans patients. So it's hard to sort of tie in the pathogenesis of one thing, but for the pathologist, it's small airway inflammation that begins the process. Now, when we think about restrictive clad, the vast majority, I would say almost invariable, but with some exceptions, is manifest as something called pleuroparenchymal fibroelastosis. And this is a new form of interstitial lung disease, idiopathic interstitial lung disease that's been accepted by the ATS, ERS, and other world societies in about 2013. But the pathology of this is very fascinating, and it's the same thing that you see in restrictive clad. Now, of course, as Dr. Natter said, we can also see focal patterns like organizing pneumonia and nonspecific interstitial pneumonia with these other changes. So tying it all together as a unifying pathogenesis is somewhat difficult, but it's certainly fascinating to observe all these changes for the pathologist.
John, that's an excellent review of what we suspect is going on underneath the hood of the pathogenesis for this. Obviously, very heterogeneous in terms of what we think is really going on.
Would like to just add something, this excellent review that Dr. English just presented, that the concept nowadays that we believe is leading to chronic lung allograft dysfunction from the immunological background is that anything that can create or trigger an inflammatory response in the lung tissue, such as could it be acid reflux associated microaspirations, could it be air pollution, could it be respiratory viruses, or and from the get-go an immune-mediated process such as acute cellular rejection. These are creating inflammation. The innate and the adaptive immune system is getting activated in a general fashion. The problem is that once you have an inflammation in the lungs, that will, without failure, followed by an alloimmune response through the memory B and T cells. And this second step, the alloimmune response, is that will potentially lead to the damage and the destruction of the organ. So innate immune system, adaptive immune system, generalized activation followed by alloimmune response and rejection. And most often, because these are slower processes, particularly the T cell arm is through an indirect immune response, indirect T cell response, indirect presentation of the antigens of the lung allograft, which were exposed by this inflammatory process. So anything that causing inflammation practically will be a risk factor for triggering alloimmune response and leading to a rejection, whether it's acute or subacute or even chronic lung allograft dysfunction. That depends on the extent of the exposure, the intensity of the immune response, and so on.
Excellent. Let's then transition this understanding of what we think is going on in terms of pathogenesis to the clinical perspective. In your review, and as we've already been discussing, we described two major categories of CLAD, the obstructive and the restrictive categories. To give some clinical context here, can we briefly summarize how obstructive and restrictive CLAD differ based on spirometry or other clinical manifestations?
Yeah, that's an excellent question. So when a patient comes to the clinic, and when we detect practically some disturbance with the organ, the way we go by this is the following. Any transplant center follows their lung transplant patients with very regular pulmonary function testing or spirometry. This is our number one diagnostic tool to monitor the function of the transplanted organ. It's just like for kidney transplant patients, they monitor creatinine. So when we see a decline of the lung function, that raises the suspicion of that something is wrong, whether it's an acute event or even could be a more subsidious, more longer term issue. So when we see decline of the lung function, a 10% decline of FEV1 warrants investigations. Usually at that point, then the first time you detect this is labeled as an acute lung allograft dysfunction, and it could be due to infections, could be due to rejections, could be many things. Once you start investigating this, then you rule out any reversible causes, such as mentioned above, and treat them. And you continue to monitor the patient, and if the lung function return to normal, then you consider this a acute lung allograft dysfunction, which was reversible and treatable. However, if the lung function doesn't return to baseline, which is defined, baseline is defined the best post-lung transplant values at least 3 weeks apart in the post-transplant period. This is our baseline that the patient could achieve after lung transplantation, and everything later on is compared to that in their post-transplant lifetime. So when the decline of the lung function persists or even progresses, then you can make the diagnosis. Once you ruled out all the reversible causes, you can make the diagnosis of a possible chronic lung allograft dysfunction. And once you reach the length of 3 months that the lung function is persistently lower and did not recover, then you make the diagnosis of chronic lung allograft dysfunction after 3 months. In an obstructive pattern, you see predominantly FEV1 decline by 20%. That's the cutoff that should meet criteria for chronic lung allograft dysfunction. Later on the disease course, and you will see FVC decline as well. Also in full pulmonary function testing, you can see obviously signs of hyperinflation with increased TLC and residual volume. However, the restrictive pattern, you see a concomitant decline of FVC and FEV1. So it's not like in obstructive, then it's usually FVC follows the FEV1, but later in the course. And that needs to be confirmed by a TLC decline, which is just again following any other restrictive lung disease, will show at least a 10% decline. So the major differences are really the FVC following or concomitantly declining with the FEV1. The other diagnosis, of course, the other main pillar of diagnosis is obviously radiographic imaging, so mostly CT scan, obviously, which I will let later on Danielle to elaborate on that, but how we distinguish between obstructive and restrictive allograft syndrome. Obviously, you need persistent opacities, some sort, in the case of restrictive chronic lung allograft dysfunction with the pulmonary function test findings.
Perfect. I think that sets a nice clinical framework for what we'd like to discuss further. Let's begin by investigating the obstructive category of CLAD. John, you had mentioned earlier the term bronchiolitis obliterans, with which many of the members of our audience are familiar. How again does the term bronchiolitis obliterans relate to obstructive category CLAD?
Right, thanks very much. So bronchiolitis obliterans, or as I should reiterate, obliterative bronchiolitis in some terminology, same kind of thing, really reflects in the obstructive phase of CLAD compromise of the small airways. It's a narrowing of the small airways. Now, as again, this is generalized inflammation that can affect the small airways, but pathologists recognize two major forms. One, which is maybe a little less common to see in tissues, would be small airways that are filled with organizing granulation tissue. We would call that proliferative obliterative bronchiolitis. But the more common kind is essentially a fixed scarring or fixed collagenous thickening of the airway wall itself. And that's called constrictive obliterative bronchiolitis, or constrictive bronchiolitis obliterans, if you prefer. And that sometimes has very few inflammatory cells in it. The collagen, the scar tissue, of course, narrows the lumen. It can be very progressive. It can be subtotal, a combination of these things. But one thing that we do get, or at least we have an intuitive feeling for, is that when it's so scarred, the pathologist would say to any clinician, well, this airway is really immobile. Not only is it stenotic, it cannot dilate and it cannot constrict under physiological constraints. So it is this sort of fixed narrowing. Sometimes the airway completely scars over, and we see this very often in explanted lungs for failed transplant, for which obstructive clad is present to some degree.
Excellent. Now let's work on understanding the imaging manifestations of this pathology. So Danielle, can you help us understand the most characteristic imaging features of obstructive clad?
Yeah, so thanks for the question. I guess most importantly in lung transplant patients, it's really important to always do inspiratory and expiratory imaging on CT. And so on expiratory imaging, we're looking for evidence of air trapping. And then on our inspiratory imaging, we might see mosaic attenuation, which is analogous to expiratory air trapping. And then we might see other features of bronchiolitis obliterans, so bronchial wall thickening, central lobular or tree bud nodules due to distal bronchial impaction.
Perfect. Now, moving from obstructive to restrictive clad, it seems that restrictive clad and pleuropulmonary fibroelastosis, which is known to our interstitial pneumonia audience, have a lot of overlap, both in terms of pathology and imaging. Can we talk a little bit about this overlap?
Maybe I'll start with the pathology. Yes, so in fact, the pleuroparenchymal fibroelastosis, or PPFE for short, it is a bit of a mouthful, is, as I said, a recently recognized idiopathic interstitial pneumonia. But we know about the disease in its other forms for many years. It's probably been around since 1960, and then categorized in the 1990s, both in Japan initially and then by the Denver group, who gave it the name PPFE ultimately. So we do see PPFE associated with a variety of other associations, as well as being idiopathic. And the self-same pathology, as I said earlier, can be seen in clad. Now, it's a mystery sometimes as to what diverse mechanisms give you PPFE, including, of course, the allo rejection context. But there are also some other things that I have to mention in the PPFE literature. I've already mentioned that it is seen in graft versus host disease of the lung, okay, often in combination with our old friend bronchiolitis obliterans too. And that's quite an interesting combination to see in those two situations. But a number of patients with PPFE have had chemotherapy for a variety of causes, fungal and mycobacterial infections, autoimmune disease. And again, there are idiopathic changes that one can see with this. So for the pathologist, the PPFE that we see classically under the microscope and grossly is virtually indistinguishable either in the clad setting as restrictive clad or with some of these other associations, or in fact in the idiopathic interstitial disease context. It looks virtually the same. The only thing that might distinguish the clad form is the coexistence, again, of obliterative bronchiolitis.
And Danielle, can you comment on the imaging findings of restrictive clad and their relationship with PPFE?
Yeah, so in restrictive clad and PPFE, we can see similar imaging findings. So we can see apical predominant pleural thickening with or without dense subpleural consolidation. And we might also see traction bronchiectasis, architectural distortion, and volume loss. It's important to note that in the setting of restrictive clad, that these imaging findings might progress faster than PPFE in other settings, so whether idiopathic or related to other etiologies. And it's also important to note that these PPFE findings are not the only CT findings in restrictive clad. So in restrictive clad, we can have other CT findings such as septal thickening, perilymphatic nodules, perilobular consolidation, or organized pneumonia reaction pattern.
Interesting. Building on that, your review describes very nicely a mixed phenotype clad, or one in which we have concurrent obstructive and restrictive features. Can we comment on how this might manifest?
Yeah, so as obstructive clad is more common, patients may initially have CT evidence of obstructive clad that we mentioned, so evidence of air trapping, non-expiratory imaging, mosaic attenuation, bronchial wall thickening, central lobular tree and bud nodules, but then they might develop CT evidence of restrictive clad, so more interstitial findings. So we might see non-resolving consolidation or ground glass opacities. And again, they might develop organized pneumonia reaction pattern, and this might evolve to an apical peripheral predominant fibrosis. But it's important to note, as Dr. English alluded to, that they might have the restrictive form first, so CT evidence of restrictive clad, but then as we look at their expiratory imaging over time, we'll note that their air trapping is becoming progressively worse. And so this is in the setting of the kind of mixed phenotype where restrictive happens first. It's always important to continue to look at your expiratory imaging and look for evidence of worsening air trapping.
May I make one comment, just maybe complement Danielle's very comprehensive description, is that even clinically on pulmonary function testing, sometimes we do see a mixed pattern that you see obstructive and restrictive ventilatory limitations coexisting in these patients, or the restrictive one evolves into a more obstructive pattern, particularly when you look at the flow volume loop. So these are kind of echoing the findings on CT scan, that these two possible different type of clads may coexist. In fact, and Dr. English can comment on that, many of the restrictive clad explanted pathologies do show, almost all of them, to different degree, but adjacent to the interstitial changes, you do see bronchiolitis obliterans patterns and changes as well.
Yes, I certainly concur with that, Dr. Natter. Sometimes the pathologist has to do a little searching for the small airway scarring, but invariably when we do sample the lung extensively, I would say it's there in almost all cases.
Wow, okay. So I personally am an imager, and I know that many of the lung transplant patients that I see have had recent bronchoalveolar lavages or transbronchial biopsies, whatever it may be. And before they come in for their CTs, I try to review these pathology studies, but I must admit, I get pretty intimidated when reading some of these reports, as I'm not always familiar with the majority of the terminology that's being used. So I was hoping that we could highlight some key ideas and key terms that we can use when evaluating our patients that are post-lung transplant that have a suspicion for CLAD. It'll really help our imagers out there better interpret their CTs.
So just maybe one thing that from the clinician's perspective, and it's important for imagers, that we would like to have actually imaging before the transbronchial biopsy or the PAL, because if it happens after, our manipulation with the allograft might be seen on the imaging and it might be misleading, and sometimes it's difficult to dissect whether it's related to the procedure or not. But so that's number one. Number two is bronchoscopies have a very well-defined role. Obviously, it's incredibly helpful ruling out infections. That's usually with the infection, bronchial aspirates, and through bronchoalveolar lavage. Transbronchial biopsies are also great tools to diagnose, and it was invented primarily when in the early stages of lung transplantation, then people identified acute rejection equals acute cellular rejection. So acute cellular rejection is supposed to be a relatively diffuse process, and we do random biopsies. However, transbronchial biopsies are not good tools, and their sensitivity is not good for chronic lung allograft dysfunction. It's not even great for bronchial type of cellular rejection, i.e. lymphocytic bronchiolitis, because quite often on the transbronchial biopsies, we are not obtaining small bronchioles, so the pathologist is unable to comment on what's happening in the small bronchioles. But certainly for the same reason, for obstructive CLAD has no role. In restrictive clad, again, just like in any other interstitial lung diseases in the immunocompetent patient population, transbronchial biopsies are not the diagnostic tool of choice. Now, BALs have another importance for us, and we do cell count with differentials because neutrophilia and particularly eosinophilia in the BAL, in the absence of some infectious processes, have some information for us in terms of what is going on in the lung allograft. And so neutrophil count over 15% is considered abnormal in the absence of identifiable infection, and eosinophil count equal or greater than 3% would be, again, abnormal. So it has a great role, but you have to take it with a grain of salt. And I would like to say that even when you try to work up a chronic lung allograft dysfunction, bronchoscopy is part of this diagnostic process. However, it is meant to rule out certain possibly reversible diseases, such as an accompanying acute rejection episode or an infection. It might not help to diagnose the clad by itself.
I certainly agree with all of that. And it's sort of my job, as well as looking at the BALs, but also of course, the small transbronchial biopsies. And so the indications for that, Dr. Natter has already outlined for you. We do, however, have the occasion once in a while to see small airways, and we do look very closely for not just fully manifest obliterative bronchiolytic changes in the airways. And of course, this is all in addition to the changes of acute cellular rejection. But speaking of the airways, sometimes the changes are very subtle, and we do our usual pathology things with special stains that highlight the connective tissue and things like that. And your readership can certainly see some examples of this in our paper under the pathology illustrations. Sometimes the interpretation is a little bit challenging, and like anything in pathology, there is a significant inter-observer variation, both in grading and classifying acute cellular rejection as well as in small airway disease. So in response to your question about informing the imaging readership or listenership here, I suppose the best answer would be, and the easiest one, if the report says anything like airway fibrosis or bronchiolitis obliterans, then there's a reasonable expectation that the imager will find some mosaicism on the high-res CTs and possibly lobular air trapping on the respiratory. But we do know that the correlation between what I might see and what the radiologist might see is not 100%. When it comes to the restrictive forms, and again, just to remind everybody, this is again an airspace and interstitial process in the main. Sometimes the transbronchial biopsies fail us a little bit. And part of that might be because of the patchy nature of some of these changes, but also because they may be fairly distal and subpleural. Certainly the PPFE changes, as we know, and as we outlined in our paper, are distinctly subpleural in their location. So that may be potentially a little hard to snag for the biopsyist. But certainly also we can identify acute and subacute lung injury with airspace fibrin, and that's certainly something that could portend ultimate restrictive clad. But I think the take-home message for me there is, even though the biopsies are random, sometimes we pick up things, sometimes we don't, and sometimes the changes are a little bit difficult to interpret for the pathologist. This is a perfect example why a visit to our friendly radiology department and getting some correlation between two forms of structure, the structure that you see in perhaps 256 shades of gray and the structure that I see on my small biopsies. We can certainly combine our efforts to make a better diagnosis for Dr. Natter and his colleagues.
Excellent. So then if we do suspect or confirm that there is evidence of clad in our patients, what then should we do from the perspective of imaging recommendations? How should we be approaching our interpretation of our CTs in terms of follow-up?
So I guess it depends on the scenario when we're imaging the patient. So there's kind of three main scenarios when we're imaging lung transplant patients. So the first is that most centers will do a yearly surveillance CT scan. The next would be if the patient attends the clinic and the clinician notices that there's been a decline in the lung function, they might want to order a CT to see if there's anything going on. And then the third would be the patient presenting to the emergency department with respiratory symptoms, so cough, shortness of breath. So then it depends on that situation and the clinical history. So it's really important to have a good relationship with your referring physician, give them a call, find out what's going on with the patient. So obviously we're going to try and do inspiratory and expiratory imaging, look for any worsening air trapping compared to their prior scans, and we'll report that. And then if there's any new findings, so any new consolidation, ground glass, we're going to correlate with the history. Does it sound like the patient has an infection going on? Could it be a drug reaction? But even if if there is a suspicion for an infection or a drug reaction or other etiology, when we see a new finding on a CT, we think it's really important to do a short interval follow-up CT, so in 2 to 4 weeks, just to make sure that this is either responding to treatment or not progressing. Because as we've mentioned, the CT findings in obstructive and restrictive CLAD overlap with many other pathologies, so infection, drug reaction, etc. So it's really important to do a short interval follow-up and make sure that we don't miss the boat with an evolving chronic lung allograft dysfunction, so that then the clinicians will be able to instigate treatment and hopefully prevent any further decline in the allograft. I don't know if Dr. Nador has something to add to that.
Yeah, I think that both Dr. English and Dr. Byrne related to the importance of collaboration and with pathology, with radiology and the clinician, because altogether we can potentially come up with a unified, if not necessarily diagnosis, but at least a course of action, what to do. Quite often, we do see on these reports of CT scan, particularly in the surveillance one, new onset of ground glass opacity, and then of course you go back to the patient, and their patient is entirely asymptomatic, even might have no change in their lung function, and so then what to do in these cases? Should we move forward with bronchoscopy or just follow up? So it's very important to consult with your colleagues and create a more unified approach to the problem. And what Danielle said is very important, the short-term follow-up. So if we see ground glass opacities, which is otherwise unexplained, often we see that, follow-up is recommended in 3 months. In a lung transplant patient, that might be a little bit too long. Because if it's an evolving, God forbid, a fungal infection, following up 3 months after that, it would be way too late. So I think that what Danielle suggested, a very short follow-up, it has an utmost importance.
Excellent. Let's now talk about future ideas. So what are some up-and-coming or future studies, thoughts, ideas in this world of CLAD, both in terms of diagnosis and management?
So that's a very difficult question to answer. I think the number one is for CLAD treatment or management would be, in fact, preventing or treating the reversible insults to the lung that happen prior to the development of CLAD, i.e. the ones that are identified as risk factors. So obviously everybody treats the acute cellular rejection, but if you have recurrent acute cellular rejection, or if it's, God forbid, a steroid refractory, then augment the immunosuppression with other just anti-thymocyte globulin or what other T-cell depleting agents. Look for other possible coexisting pathways, such as antibody-mediated rejection. If you diagnose a possible, even a definitive antibody-mediated rejection, treat that. Treat the acid reflux disease or microaspirations. There is data about fundoplications preventing or at least delaying the development of CLAD. Again, referring back to the beginning of our discussion about how non-immune mechanism, creating inflammation and leading to follow-up autoimmune processes. So treat the acid reflux, treat the respiratory viral infections, which might be very different than how we approach with respiratory viral infections in an immunocompetent population. We don't treat because it's a self-limited disease. However, in transplant patients, because of the immunosuppression, and particularly in lung transplant patients, because the target organ is actually the transplanted organ. So there is an autoimmune memory in the immune system against these organs. So anything, again, that is causing inflammation there has a potential to develop a rejection episode and plaque. So prevention, I think that would be the good way to do it. Now, if we do have, and often obviously we fail to, unfortunately, to arrest this progression, and then there are certain modalities that have been investigated and used for chronic lung allograft dysfunction with more or less success. So for example, extracorporeal photopheresis had been shown to be a viable option for obstructive clad, less so for restrictive clad. Alemtuzumab had been used for both with some success. Now, we have to understand that these both are probably slowing down the rate of decline of the lung function, but they are by no means they are curing the disease. And then for very fast progressing clads, some papers are suggesting using total lymphoid irradiation. Other measures would be more from the medicine type of things, or that you would use some anti-inflammatory drugs such as azithromycin, which nowadays we are using from the get-go of lung transplantation. Then on the same pathway, not exactly the same pathway, but the same concept is using montelukast for obstructive clad as an anti-inflammatory agent. Inhaled corticosteroids with long-acting beta agonists have a very weak evidence whether they are helping, particularly for obstructive clad or in the mixed clad pattern. That these are more like chronic treatments. And lastly, for restrictive clad, and now there are studies also for obstructive clad using antifibrotic agents such as pirfenidone and nintedanib that potentially could bridge the patient to retransplantation. But again, it might slow down the process and the decline, but by no means it's a curative disease. And as I mentioned, the final option would be for candidates who are appropriate candidates is retransplantation, unfortunately, for clad.
Excellent. Well, this has been a great discussion, everyone. Are there any final thoughts before we conclude?
Maybe if I just can make something, and maybe it's a very radical approach that we tend to, in medicine in general, we tend to categorize things and boxing things. So we try to say that there is acute cellular rejection, and there is chronic rejection, and there's obstructive and restrictive, and we try to fit each patient into these categories. But I think that what we need to understand in lung transplantation, and I guess in any other transplantation, that these rejections from one end acute to the other end to a chronic rejection, this is actually a spectrum of diseases, and one evolves to the other, and some of them are more acute and others are subacute, and then others are much slower progressing. But it is a spectrum that we need to consider. And then the other comment I wanted to make, that in particularly with the chronic lung allograft dysfunction that Dr. English described beautifully here, in terms of the insult of the organ where it happens, it might, depending on whether it's primarily affecting the smaller airways or primarily affecting the interstitial area, that will determine where you see the predominant manifestation of clad, i.e., it will be predominantly restrictive or predominantly obstructive. But then again, the damage can extend from the interstitium to the small airways and vice versa from the airways to the interstitium. And therefore, it is probably just different phenotypes of the same process. It's response to injury.
Spectacular. I think this has been an excellent review of not just CLAD, but all sorts of manifestations of disease, approach to diagnosis, and subsequent management of these patients that are clearly often presenting diagnostic and therapeutic dilemmas to lung transplant patients as being. Thank you, everyone, Dr. Nador, and Dr. English, and Dr. Byrne for joining us. I really, really appreciate your time and expertise.
It's been a pleasure. Thank you.
Thank you for having us.
Great. And to our listeners out there, thank you all for tuning in. Once again, my name is Praveen Ranganath, and I've been the host of the Radiology Cardiothoracic Imaging podcast. If you like what you hear from us on the podcast, please rate, review, and subscribe to us. We will see you next time.